Thanks. So now it's my pleasure to introduce my long-term colleague and collaborator, Dr. Phuong Mai, who is now the medical director of the Clinical Cancer Genetics Clinic at the McGee Women's Hospital and University of Pittsburgh.
Well, thank you. Well, first of all, I'd like to thank the organizers for the invitation to share with you some of the findings or some of the data in the surveillance study from the Li-Fraumeni syndrome study at NCI when I was until very recently. And I'd like to emphasize that it really is a privilege to be here speaking with you today. Let's see. All right, so a quick introduction. The NCI LFS study was opened back in 2011, and it was designed to be a long-term prospective natural history study with the intention to address several of the questions that's been posed earlier today as well as yesterday's. There's still a lot we don't quite understand about the syndrome, so the hope is that we will be able to address several of these questions in the near future. But one of the main aims of the study is to try and see if we can somehow come up and establish with an effective screening study whether or not that's the same screening study for everyone, so it can be, or it can be individualized. As you heard mentioned yesterday and as well as today, cancer risk seems to vary between person to person depending on various factors. And so whether or not we can use those data or information to individualize the screening, that would be the focus of the surveillance program. So that's the website for the NCI study. If you need more information either about what we do, how we do things, the team members, and lots and lots of other information, you can go. There's the website. For the eligibility criteria for the study is family members from families who meet either the classic LFS or the Birch LFL diagnostic criteria. After the past couple of days, I trust that you know what those criteria are, and I'm not going to elaborate on the details of those. Individuals who are mutation carriers or first or second degree relatives of a mutation carrier. Or individuals who have 3 or more LFS-related primary cancer, and or persons who have a history of adrenocortical carcinoma or choroid plexus carcinoma, regardless of when they were diagnosed. The slide is a little outdated. It's a couple of months old, but as of March or so, we've had up to about 700 participants in our study from 159 families, and a third of those families meet the LFS criteria. About a little less than half meet the LFL criteria, and several other families meet various other eligibility criteria for the study. So what I'm going to be focusing on today is our screening surveillance. So to be eligible for the surveillance protocol, participants have to be a confirmed mutation carrier and have not had active cancer treatment over the previous 6 months. Our protocol is based very closely on the Toronto protocol with some slight modification. So for children up to the age of 16, we do obtain blood work every 4 months, abdominal ultrasound every 4 months, and yearly brain MRI and rapid whole body MRI. For the adult, we obtain blood work every 4 months, excuse me, yearly brain MRI as well as whole body MRI. And for females who still have intact breast tissues or who have not had mastectomy either for treatment or for risk-reducing purposes, we do get a breast MRI annually and a mammogram annually starting at the age of 40. Mammogram was optional between the age of 20 and 40 after a discussion of the risk and benefits of mammography between that age range, given the sort of slightly different risk and benefits profile for that age group. And colonoscopy every 3 years starting at the age of 25. So I'm going to be talking about just the 100 individuals who enrolled in the screening program up until now, and only on the baseline screening. Several of these individuals have had more than one screening, but I would just be focusing on the first screen study. So we have 100 individuals, 59 meet the classic LFS criteria, 33 LFL, 2 people with multiple primary cancers and 6 with de novo mutations. 67 are females, 33 males, and the age range is between 4 and 68. So for the, I'm going to be talking about the findings for the various different studies separately, and at the end I'll put it all together. So for whole body MRI, we performed 100 at baseline, and of which about 20 has some abnormalities that require additional study. And we found a lot of abnormalities. As mentioned by Dr. Evans yesterday, there are lots of lumps and bumps, there are a lot of benign findings. The difficulty is when you do the first screen, you can't be quite sure as to what it means, and so it will require additional follow-up studies to see if you can sort out what it is that you're seeing. We did see a lot of findings in the abdomen, liver cysts, liver lesions, nodules close to the pancreas that we weren't quite sure as to exactly what they meant. And most of the studies, the follow-up studies varies between X-rays, chest CT, dedicated MRIs, sometimes multiple imaging studies, again, to further evaluate the finding. 17 of those 20 turned out to be we were able to confirm or to verify that 17 of these 20 were benign findings from additional studies. We did see a lot of sort of bone lesions or lesions in the intramedullary that, again, weren't quite clear as to exactly what they meant. As I mentioned, 17 we were able to sort out with additional imaging. For 3 of them, we ended up getting biopsies. So this is the whole body MRI from a 45-year-old woman. We saw that little spot there in the lung. I don't know, you can't quite see back in the back of the room. It's a little small, but we did see that. So we went ahead and get a chest CT, which showed a 0.5 centimeter nodules in the right upper lobe. So she went ahead and get a biopsy, which turned out to be non-diagnostic. Given the sort of the high suspicion, she went ahead and had a wedge resection, which showed a stage 1B lung adenocarcinoma, which was completely resected, and she didn't need any additional therapy. The second case is a 29-year-old man. He has a lesion here in the posterior of the rib cage, which shown here as well. It's about 4.5 centimeters. X-ray didn't show any concerning findings, so we decided to monitor and repeat a dedicated chest MRI in 3 months. And the follow-up MRI did show that the lesion has gotten a little bigger. So he went ahead and had his biopsy done, which showed an osteosarcoma, which led to resection. It was a grade 2, intermediate grade osteosarcoma, which was resected, and he went ahead and received chemotherapy. The third case is a 10-year-old girl who has this in her leg. Again, X-ray didn't show anything concerning, so we decided to monitor. But clinically speaking, she did have a little bump in her shin. It wasn't painful. She didn't remember hitting it. She didn't remember running around, or she doesn't play any sport. So clinically, it wasn't likely to be some sort of injury. On a clinical exam, it got a little bigger after a few months, so she went ahead and had the biopsy done, which showed a fasciitis. So those are the whole body MRI. For the brain MRI, of the 100 that we did, we found 5 abnormalities. 3 of them require additional follow-up studies with either a dedicated MRI or a short follow-up. There's a 31-year-old woman who was completely asymptomatic. Her brain MRI showed some punctate lesions, which was suspicious for an inflammatory demyelination process, for which she underwent a workup and was diagnosed with multiple sclerosis. One of the, I suppose the concern is that she was completely asymptomatic. We diagnosed her with multiple sclerosis, and she did undergo started therapy. Whether or not that would have changed her course of the condition, we can't be sure on whether or not she would have been fine until she became asymptomatic and started therapy. Then we have no way to tell whether or not that made any difference. And so the fourth case is a 13-year-old girl who was completely asymptomatic. We did genetic testing on her a few months prior to her starting the screening protocol because there is a mutation in the family, and she tested positive. So she started on the screening protocol, and we found this approximately 5-centimeter lesion that she went under surgery for, and it was a grade 2 astrocytoma. It was completely resected, based on the histology of the tumors and other factors, the decision was to not start her on adjuvant therapy. So that's all she needed was the surgery. And this is a 28-year-old girl, I'm sorry, forgot her age, who had a previous history of breast cancer, and we saw this about 5-millimeter lesion in the thalamus, and we couldn't be sure whether or not it represented a new primary brain tumor or metastasis from her breast. So she underwent a biopsy, which showed a low-grade glioma. Given the size of the lesion, the histology, and the location, the decision was to continue with close monitoring with frequent brain MRI. And the lesion has remained stable after a few years now. There were 17 participants on the study who had breast MRI, of which 3 showed some abnormalities. The first 2 has enhancement lesion, which was followed up with an ultrasound and biopsy. Both of them turned out to be DCIS. This woman had a lumpectomy followed by adjuvant hormone therapy. This woman had a mastectomy and a contralateral risk-reducing mastectomy. There's a 35-year-old woman who had a small nodules in her left breast that was followed up by MRI in 6 months. In terms of the other screening tests, we had 10 individuals who had colonoscopy at baseline, which didn't show any abnormalities. Neither did the abdominal ultrasound nor the labs, nor physical exam. So as a whole, when you look at the screening, sort of the surveillance as a whole, we did 100 studies, and there were 28 that require additional studies, be it imaging studies or biopsies, which led to a diagnosis of 6 cancers. For a cancer detection rate of 6%, keep in mind though that we did see a lot of other findings that require additional studies, which turned out to be benign processes. Up to about 80% of the first findings were turned out to be benign. All of the cancers that we detected so far was detected by MRIs one way or the other. So the blood works and the ultrasound and the colonoscopy. We haven't, with colonoscopy though, the exception is that we only done 10. We only have to do 10. So with additional, we'll add to the entire surveillance protocol. So then we do have 6% is not a bad cancer incident rate, detection rate, but we do have to be careful with the high false positive rate that we do have on the study. The thing is, again, we do see a lot of lumps and bumps, and the first time you see it, you can't quite sure what to make of it. But the idea is with additional study, now that you have a baseline, you have something to compare to, so that should really go down significantly. And the other thing is, a whole body MRI is not something that's done readily, everywhere, all cancers around the country or around the world for that matter. And it does require some degrees of expertise. I mean, the radiologists at NCI, or NIH really, been doing whole body MRI for quite a while, and they was doing whole body MRI even before we have our protocol started, so they're quite experienced. And even with that, we do see a pretty high rate of false positive rate. So that's another thing to keep in mind. And we do not have a comparison group in our study. We don't have say a group of individuals with a mutation who are not having screening to compare and see how well the screening works. And we don't have a group of individuals without a mutation to sort of better evaluate the screening protocol in terms of detection rate or false positive findings. So that's some of the limitations of our study. And I do like to emphasize that these are preliminary findings. These are on 100 individuals, and these are just the baseline findings. So the annual screening is ongoing. As I mentioned earlier, there are several participants that have now had more than one screening. So with that, we will be able to collect more data and get more data information to really try to sort out as to how best to go about doing this surveillance. I mean, there are several other surveillance protocols going on around the world, really. There's the often mentioned protocol, Toronto protocol. There are the screening surveillance program in the UK that Dr. Evans mentioned yesterday. There's one in France, one in Australia, and one in Boston and one in Houston. And my hope is that with the data from our study and the data from all the other studies that are ongoing, or the studies that will be started in the near future, we will be able to get to an optimal screening surveillance, again, whether or not it's the same protocol for everybody, or we could somehow come up with a better way to design a surveillance for the individuals based on the risk and what else going on would be the idea. And with that, I would like to thank all the study participants. Clearly, the study wouldn't have happened without their help and their support and their willingness to come to Bethesda every year and stay with us for between 1 and 3 days. Can be quite stressful, going and staying and having to be away from families, taking time from work. It's quite an effort, and it's quite a commitment, and for that, I thank you very much. And then the Live Consortium, which has been again mentioned many times at the meeting, which is a great thing. And then, of course, the NCI LFS study team, with everybody working on the study. We will get someplace soon. Thank you.
Time for questions? All right. Just quickly, about the great presentation. Thank you for sharing that data with us. My question is about the lab work. So you said that you didn't find anything with the lab work, and you did say that you were checking every 4 months. When you say you didn't find anything with the lab work, was that the first lab work, and have you found anything subsequently? Because this is always a big discussion with the hematological malignancies.
Exactly, right. So so this is just baseline, but I can tell you, though, that we still haven't seen anything on the lab work with the 4 months lab work, and that varies between baseline and up to 4 years now. And
have all 100 patients continued to receive lab work every 4 months?
Pretty close. Okay. I mean, there's some miss here and there, but I say on average, probably more than 90% get lab work within a month, within the sort of 3 to 5 months window.
Right. And I will say, we also have found a lung adenocarcinoma with the whole body MRI. So
which is quite amazing, because lungs is not something that you would expect or anticipate to see very well
and the
with
patient's
MRI.
doing very well now. So
exactly.
Okay.
So
thanks.
Many thanks for this additional pilot study. highlighting the efficiency of MRI and also the high frequency of incidental finding because you had a high risk. I would like to go back to the question of colonoscopy because although we cannot exclude that we have some population effect, as demonstrated by our colleagues from Asia, we are not all convinced by an increased risk of colorectal cancer. We have performed updates of the pedigrees identified in France, and definitely we have no evidence at all of an increased risk of colorectal cancer. So it's always a question of compromise when we are doing follow-up. So are you really convinced by the interest to include colonoscopy in your protocol?
Well, so I can tell you that in our study, there are several families with very early onset colorectal cancer. So again, it goes back to so is it family-based, or is there something else going on, and whether or not we should decide whether or not colonoscopy is indicated, and at what age we should start based on perhaps family history that would guide us in deciding whether or not that should be a component, and again, when to start. I do think, though, I do think that colorectal cancer risk is increased in Li-Fraumeni syndrome, perhaps depending on the population and depending on the family. But again, I guess the idea is to once we get enough data, we can sort of put it all together and see whether or not it's something that should be recommended for everybody or somewhat individualized. Thank you.